Ober's.
Ober. What are we checking for? IT band. So you would have the patient sideline. And you would then, grabbing the leg like this, you're going to bring the leg up. You're going to abduct that leg, a little bit of internal rotation, and just let it drop. And normally, remember, it should drop smooth. I mean, you don't want to just let the knee hit the other knee, but just, kind of get a feel. Is there a normal, is it going to adduct smoothly? Or is there going to be, sometimes if there's a tight IT band or a tight TFL, it'll just stop or it'll kind of ratchet down. And that's a sign that there's contracture of the IT band or problems with the tensor fasciae lata. And then you would follow through with going in there and then, and then just palpating down that IT band and that TFL. If you suspect contractures of the IT band, that's when we talked about, foam roller or like real deep tissue massage just to break up any adhesions is really going to help with that. They are. They hurt really bad, but they're really good, especially if you have any patients that have IT band issues. And believe it or not, I would say a lot of patients do, and some just don't realize that they're kind of dormant, dormant issues, dormant tightness in them. So Thomas test. What are we looking at with Thomas test? So remember, we're looking at hip flexors, mainly like iliopsoas or psoas. You're going to have the patient. Can I have you lie on your back, please? So if you wanted to check, remember, let's say we're checking the left side. We're going to have the patient bring this knee up to the chest and either grab behind or at the knee. And normally, this thigh is going to come up a little bit. That's normal. But if it pops up like this, where you can actually fit your fist or your arm underneath there, that's a positive sign. That's a sign that there's the anterior tightness of that iliopsoas. It's called, the hip flexors are extremely contracted on that side. That would be, you could then, if you just wanted to confirm what muscles were involved, you can go in then and palpate some of the anterior thigh muscles. Even have the patient, flex their leg and go in there. You can, palpate the belly of the psoas muscle, see if there's any contractions in there. What's interesting about the psoas muscle? It's the only muscle that does what? As far as origin or insertion. Remember, it's the only muscle that attaches to the disc. So sometimes when people have contractures of that iliopsoas muscle, they're going to, the tighter that muscle is and the longer it stays tight, the more it can cause issues with the disc and the low back in particular. So Patrick's test, or Fabre's, or Fabre's, however you want to say it, what are we looking at there? Yep, it's the figure 4. What is it? Flexion, abduction, and external rotation. That's where that Fabre comes from, or Fabre, depending on how you want to pronounce it. Remember, you're bringing the leg up and over like this. So we're going to be checking, we're checking for hip issues. And you're going to almost do like a figure 4 on the patient, and then just a little bit of overpressure. If there's any issues with the hip joint itself, remember the hip is a ball and socket joint. Normally, and with most orthopedic tests, they're not supposed to, in normal tissue, normal patients, they shouldn't cause any pain or discomfort. Sometimes by doing that test, there's going to be pain in that hip region. Sometimes that can be caused from osteoarthritis, degenerative joint disease in that hip region. That ball's not articulating correctly in that socket. Sometimes it can be due to bursitis, those type of an issue. So this test is going to help you differentiate between a true hip lesion, or sometimes, we talked about when we get into low back stuff, Sometimes lumbar spine can refer to the hip. So with this test, usually it's going to be positive for pain in the hip, nowhere else. So yes?
So if you're suspecting, so if there's some pain, there should be no pain there. So how do you get, so if it's bursitis, there's not going to have a pain.
Bursitis, there might be some pain.
So would you determine if it's bursitis by tenderness in the cancer?
Yep, exactly. That would be perfect. You would then follow up. Remember, no orthopedic test is 100%. You know, you also want to remember we talked about history, how the patient presents. You know, and also these tests are just helping to, you know, kind of like unpeel layers on an onion. You're trying to get to that, to the core of that problem. So then, yeah, if you suspect it, then, you know, bursitis, you would then go to the greater trochanter. Remember, there's usually that pinpoint tenderness. That patient has that, aha, that's the pain. And it's not, you know, a diffuse type of an issue. With osteoarthritis, remember, it's going to be a more diffuse, dull ache. Patient's going to have, you know, sometimes, well, most of the time, pain's going to be worse in the morning, better as the day goes on. You know, their range of motion is going to be a little more restricted, inactive, only passive range of motion. Trendelenberg's test, remember that's to evaluate specifically like glute medius, but you know, the abductors in general, the stability or any weakness of those muscles. And you're going to have the patient, have them hold on to something, but you're going to have that patient, you know, bring one leg up. If on the opposite side that muscle is weak, you're going to notice that their pelvis is not going to be supported and it's going to sway. Eli's heel to buttock test. With Eli's, you're going to have the patient, can you turn on your stomach, please? You're going to bring that leg up, and you're going to push it towards that opposite buttock. With this test, remember, you're going to ask the patient, do you have any pain? And then if they say yes, you're going to have them point to where it hurts, because this test is going to help to differentiate between a low back issue, a hip issue, or sometimes a tight anterior muscle of the hip type of an issue. So usually the patient's going to then, yes, that hurts. It hurts right here, and you know they're going to point to L5, or it hurts right here, and they're going to point to their hip. Then you would follow that up with then palpation to that area, whether it be hip issue, low back issue.
So it's just the side between low back
And hip. And sometimes that side too, depending on where that patient runs to. So then the labral. Remember the labrum of, we have labrum in both the hip joint, and we have a labrum also in the shoulder joint. It's going to help, remember, it helps to almost act as a suction cup and keep that ball in that socket. Also gives it a little more stability. Sometimes those labrums, the labrum can tear. Much like the meniscus, much like any other piece of soft tissue. Usually it's going to be an anterior labral tear. And that's where this test comes into play. So you're going to have the patient lying, can you lie on your back, please? So you're going to flex, adduct, and then internally rotate that leg. And you're looking for pain, obviously, in the hip. Sometimes they're going to complain of a locking, or you're going to hear a clicking. You're not really going to feel it, but that's just going to help to differentiate. Like, let's say there was a positive Patrick's test, and you suspect a labral tear. Patient heard a rip or felt a tear in that hip region. You would then follow it up with this test to just confirm that. If there was a labral tear, what would you do? Who would you send to? What test might you order? What's that? Right? And then you can follow it up with an orthopedic surgeon. Sometimes, you know, your more mild to moderate tears can be conservatively treated. Much like the meniscus, though, sometimes that little piece can get stuck in that ball or that socket and can inhibit some of that range of motion. So, Periformis test. Who's going to be more affected by Periformis entrapment type of syndrome? Males or females?
Oh, that was a guys, wasn't it? Oh, never mind. Take it all back.
Again, it's because of that the Q angle again. You know, it's going to put more strain on that Q angle. So you're going to have the patient lying on their side. Can you lie on your side, please?
What was the one that was for guys?
And you're going to, with the affected side up, I'm going to scooch in here to this other side of the table. And you're just going to, you know, have the patient move to almost where this that you can kind of pull down towards the floor and then up towards their head to stretch out that piriformis muscle. You can also, after you have them, you know, push down and then push towards their head, you're going to stress that piriformis area. You can then have them gently push up into your hand. So push this up into my hand and see if that reproduces any of their pain. You know, that would be a positive piriformis sideline test. You know, then go in there, you know, palpate to see if there's any tightness and contractions of the piriformis. And then just take it from there. With piriformis, try to remember, we went over some stretches for that. And so, you know, trigger point work is really good for piriformis and travel because you need to really, that piriformis, remember most people, the sciatic nerve travels right under that piriformis muscle, so when that gets tight or contracted, it's going to clamp down on that nerve and cause a lot of discomfort. So do you guys want to, why don't you work on those couple of tests now?